Good evening. This is Dr. John Bennett broadcasting from Miami. Tonight we have another in a presentation in a subject regarding brain tumors. And we have the distinct honor of having Erin Dunbar, MD, a physician that's practicing now in Atlanta, and she's part of the Anderson Cancer Network of Houston. And tonight we also have a distinguished guest, a medical student, a neurosurgical prodigy from Croatia. Good evening, Slaven.
Good evening, Dr. Bennett. Thank you for having me here. And I'm a medical student in Croatia. I'm in Zagreb now. And I just wanted to say how much I appreciate this opportunity to listen to this great presentation.
Yeah, I thank you for all your help in assembling everything. And okay, Erin, welcome. And could you say a few words about yourself and what you're doing, etc., before you launch into your presentation, please?
Yeah, thank you, Dr. Bennett. What an honor it is to be able to have this platform. I am trained in medicine, medical oncology, and neuro-oncology, and then complemented that with a fellowship in palliative care and hospice because I really felt that I had an incomplete ability to relieve suffering at the same time I tried to modify disease. And my area of specialty is diseases that affect the brain and the spine, particularly malignant and benign, but also things that are neurologic sequelae of tumor treatments that we fight in the rest of the body. So I'll be describing two lectures today. One is, what are the things that patients ask neurosurgeons about the modern management of brain tumors? And then the second talk will be modern oncology drugs that affect neurosurgery decision making. And these are really good for audiences, not only our neurosurgery colleagues, but intensive care unit colleagues, neurologists, medical oncologists, and radiation oncologists. And I hope that this information is valuable to you. My contact information is available on the slides if I can ever be of help.
Okay, you want to start your presentation, please?
Sounds wonderful. Hi, my name is Erin Dunbar, and today I'll be talking about oncology drugs affecting neurosurgical decision-making. I direct the neuro-oncology program at the Piedmont Brain Tumor Center in Atlanta, Georgia, United States, and we are network affiliate members of the MD Anderson Cancer Center. I have no relevant disclosures to talk about today. What I'd like to open this up is identifying drugs that affect neurosurgery decision-making is really based on the foundation of identifying the drugs. For instance, they can come in all shapes and sizes, and patients don't often say the names of the drugs in the ER or the ICU, and you have to explicitly ask. They're not always relevant on the first medication sheet that is done, and it takes a lot of due diligence. They could cross the spectrum of hemostatic modifying agents, immunosuppressive agents such as steroids or chemotherapy, and new classes of drugs like immunotherapy, bisphosphonates, and biologics. So this is a Venn diagram just to show that these drugs really do affect perioperative outcomes in our patients. And that could be ICU patients, radiation oncology patients, but neurosurgery is the paradigm today. So if you look at the four large circles, immunocompromise, hypercoagulability, edema or inflammation, mobility, deconditioning, and deficits. And then you look at how they all interconnect from marrow dysfunction, hyperglycemia, infections, hemorrhages, blood clots, and drugs like Avastin and steroids all in the mix. So really it's a complex set of things we're trying to do to assist patients. I'd first like to talk about hemostatic modifying agents. And the common vernacular for that are blood thinners or anticoagulants. And they can come in various shapes and sizes. Some of them are vitamin K antagonists, others direct inhibitors of clotting factors, and a third class are indirect inhibitors of clotting factors. And then, of course, there's antiplatelet agents and anti-angiogenics. So first to blood thinners or anticoagulants. They come in two basic forms with subgroups. So what are now termed direct oral anticoagulants are oral medications that directly inhibit a specific enzyme within the clotting cascade. And they come in two basic forms. The first are direct thrombin inhibitors, And common agents are Pradaxa or Dabigatran. And then they have some IV agents, Argatroban and Bivalirudin. And then there's also direct factor 10A inhibitors, and we know them as Xarelto and Eliquis, brand name in America. A separate type of blood thinners are other anticoagulants, not like those, that indirectly inhibit factors 10A and thrombin. Key examples would be heparin or heparinoids, either unfractionated heparin or low molecular weight heparins, and they inhibit factor 10A and to a lesser extent thrombin. Examples include fondaparinol and other medications such as that. And then lastly, warfarin, which reduces the synthesis of certain functional factors such as 2, 7, 9, and 10. And what they do is reduce the ability to generate active thrombin indirectly. So this is the coagulation cascade that strikes the fear in most of us. But this is really just to describe that anticoagulants overwhelmingly affect just two clotting factors, 10A and thrombin. And when we think about modifying those and monitoring them, we have to think of labs such as complete blood count that look at platelets, or renal function that demonstrates how most of these metabolize, or liver function, which is reminiscent of the manufacturing of many of our blood clotting factors. And then lastly, the blood thinning parameters, PT, PTT, and INR as well. So this is also a chart to describe the expected effects of anticoagulants on commonly used anticoagulation tests or coagulation tests within the lab. And this is meant to be a busy slide, but it's for reference. So it starts with the drug class on the left, the drug to the next left, brand names, and then a variety of the clotting parameters that we can do in everyday testing. And the key point is that there's arrows, pluses and minuses, which really demonstrate that this is a complex interaction of test results that require a high level of need for our hematology and laboratory colleagues. A little bit more on direct oral anticoagulants. They reversibly and directly inhibit coagulation factors. They have a shorter half-life than warfarin, and very importantly, they do not rely on gut absorption or gut transit time. So if we have patients that have nausea, vomiting, diarrhea, constipation, drugs like warfarin can under and over metabolize. And furthermore, vitamin K clotting factors or other bacteria can mess up the metabolism of warfarin. So sometimes these direct oral anticoagulants are safer and more even in their anticoagulant effects. The other way of saying that is they have a very steady PK and PD unless extreme renal or liver dysfunction. Major bleeding is very low and similar to or lower than other oral anticoagulants. And that's important because everyone was scared of these drugs when they first came out, but they're actually even safer in most hands than warfarin. The degree of anticoagulation depends on the dose and the interval since the last dose. So it's really important to get a good clinical history of the last time the patients took the drug. And over the next few slides, I'm going to show some cases of how different testing may be helpful. But very importantly, normal coagulation testing does not necessarily mean that the patient has normal blood clotting, and additional aggressive intervention or monitoring or prevention may still be needed. Truly, judgment is required in all cases of bleeding. Risks to the overall risk of the patient, and we must try to understand the bleeding dynamics. Is this a one-time bleed and it should have already been coagulated or fixed? Or is this a bleed that we expect to be ongoing or worsening? This is another slide for reference found on UpToDate, and this just describes that there are algorithms that are published that help guide clinicians to the type of bleeding, what agent is being used, and the possible interventions. For instance, bleeding could be described as major bleeding, such as intracranial, retroperitoneal, compartment syndromes, or gastrointestinal. And minor bleeding may be minor epistaxis, uncomplicated peripheral or soft tissue bleeding. And then based on that, it may be just supportive care, transfusions, or blood product transfusions such as activated clotting factors, FFP, etc. A little bit more on the risks of bleeding or how to deal with patients with active hemorrhage. First and foremost, we want to discontinue the oral anticoagulant. We want to address the hemorrhage anatomically. For instance, can we address it with surgery, endoscopy and cauterization, embolization, or other local therapies? Can we give transfusions of either red blood cells, platelets, or direct clotting factors? Are there any agent-specific reversal agents, such as protamine with heparin? Are there any pro-hemostatic therapies, such as anti-fibrinolytic agents, that could be used in emergencies? There are a few guidelines for specific procedures, such as surgeries or other invasive procedures. Most importantly, we want to consider delaying any procedures unless absolutely emergent until the anticoagulant half-life has dissipated. And especially if there is abnormal renal function, we need to give extra time. If the procedure must occur, we must consider using agent-specific reversal agents or blood products. Another question frequently asked of me is the resumption of anticoagulation, and that is highly individualized. There are guidelines available on UpToDate and in other references such as PubMed. For instance, one including when to restart anticoagulation in patients that have had a prior intracerebral hemorrhage. These are excellent articles that can serve as guides for all of us. And lastly, a good note is that there are many antidotes to these agents under development. Now let's direct our attention to warfarin. Again, for patients with elevated risk or active hemorrhage, the first rule is to discontinue. Furthermore, we can use vitamin K, either oral or IV, depending on the time in which we need to take for the blood to thicken. If emergent or urgent, we can consider using either prothrombin complex concentrates for rapid reversal. This tends to have similar efficacy as FFP but lower side effects, or FFP if there's massive bleeding, because this replaces many other factors as well. And a word of caution, around the world we're using much less recombinant factor 7A because it doesn't supply any of the other vitamin K dependent factors, and there are a lot of prothrombotic risks. Furthermore, we can use transfusions, especially if there's concomitant low platelets or dysfunctional platelets from antiplatelet agents. And then lastly, we can consider antifibrinolytic agents such as tranexamic acid or aminocaproic acid, especially in times where there's oral or mucosal bleeding. I want to direct our attention now to anti-angiogenic agents, a different reason patients can bleed affected in our patient care. Anti-angiogenic agents are vascular endothelial factor receptor blockers. They are blood vessel permeability modifiers. They reduce symptomatic edema, and they cross the blood-brain barrier in ways that they decrease the contrast, like gadolinium or CT dye, when we use those imaging modalities. They're used for a variety of indications, including for new and progressive glioblastomas, such as bevacizumab, a monoclonal antibody against the receptor of VEGF. And they can also be used for radiation necrosis, vasogenic edema, and they have non-CNS causes, such as angioedema, ocular macular degeneration, and many other uses. Very importantly, patients won't call these chemotherapies, and they're often not listed on medication sheets, so we have to ask. A little bit more about these agents. They do have unusual toxicities. They can cause both arterial and venous thromboses, and not double or triple, but slightly higher when looked at over 6 to 12 months. But yet they are idiosyncratic and are important when they occur. They can also cause arterial and venous hemorrhage. and again, not significantly above population baseline, but they can be idiosyncratic and very serious when they occur. But very importantly, they can cause delayed wound healing or breakdown. So they don't cause a DIC or bleeding in real time, but if people have had procedures, they can cause a delayed dehiscence or perforation or breakdown. Additionally, they can accelerate known or unknown but pre-existing vascular disease. For instance, coronary artery disease, vascular disease in the cerebrum or peripherally, hypertension, proteinuria. They also cause fatigue and very rarely reversible posterior leukoencephalopathy encephalopathy syndrome. A little bit more about safety with hemostatic modifying agents. It's very important that we evaluate the risk of thromboses, the risk of hemorrhage, the risk of wound healing, and the risk of cytopenias, both the number and dysfunction in our patients. And this requires a good H&P and many times discussion with our colleagues. When we think about using agents that modify the hemostatic potential in patients, whether bleeding or clotting, it's important that we consider in high-risk patients if they may have an occult intracranial hemorrhage, whether arterial or venous, at baseline before initiation of any of these drug products. They're well considered to be safe to be used in treated brain tumor patients. And that's typically defined as patients that have already undergone surgery and or radiation but are well within the 4 to 6 postoperative or post-intervention period. It is not to be used for fresh and new hemorrhagic metastasis or active bleeding situations. And when we employ these agents, we must actively and routinely screen patients for toxicities based on treatments and comorbidities. A little bit more about safety of anti-angiogenic agents in these patients. Well, first of all, ask about them. A given half-life of many of the agents is about 20 days. So that's an important note. And it's also important to note that there are no reversal agents or antidotes like there are in some of the antiplatelets or anticoagulants. So for elective procedures, we should hold for about 4 to 6 weeks. If it's a major procedure, such as a surgery, and hold for about 2 to 3 weeks if it's a minor procedure, such as a root canal, a tooth pull, etc. For urgent and emergent procedures, usually there is no intraoperative or perioperative issues, but we must have conservative closure, consider patients to stay in a higher level of care, closer monitoring, etc. And we should monitor for post-operative delayed sequelae, such as delayed wound dehiscence, very aggressively. Now, safety in combining all these agents, including anti-angiogenics, antiplatelets, and anticoagulants. Believe it or not, more and more patients are on all of these agents combined for their various active comorbidities. So a few rules of the road. The first is antiplatelet agents can cause platelet dysfunction, not necessarily just low platelet numbers. So ask about it and know that even platelets may not be functioning correctly. Know the half-life of these agents and when these drugs are out of patients' systems. Next, know the indication for platelet transfusions. Know the lifespan of an endogenous platelet is about 7 to 10 days, but when we give transfused platelets or when patients are sick, platelets might only last in a patient 3 to 5 days. Think about antifibrinolytic agents, especially for patients with oral or mucosal bleeding. DDAVP can sometimes be used for platelet dysfunction. And in general, there are no absolute contraindications for any specific platelet count level and the use of any of these agents. It's really a risk-benefit ratio. Furthermore, there are no absolute contraindications to antiplatelet agents and either of these anti-angiogenics or most chemotherapies. Once again, it's a highly individualized risk-benefit ratio. Platelet functioning has become more common internationally, but it is rarely helpful in these scenarios. It predominantly rests in the world of cardiothoracic surgery, stroke medicine, etc. A little bit on the evaluation and management of thromboembolism in CNS tumors. Thromboembolic disease is one of the top 4 comorbidities that end the lives of patients affected by brain and spine tumors. To treat, we can think about local treatments, whether interventional removals using evacuation procedures, lytics, etc., or there are systemic agents such as unfractionated heparins, low molecular weight heparins, etc. They tend to be very safe and effective. The reason that many of these agents get a bad reputation is because oftentimes there are supra-therapeutic levels, and that is really when the risk gets very high in these patients. In such a situation, we want to think about prompt evaluation by specialists in considering using reversal agents, such as the case of heparin and protamine, or platelet transfusions or blood factor transfusions. This is an excellent slide that I like to share with house staff and my colleagues to go through the algorithm of how we talk to our patients, our colleagues about the risk management of patients that have primary metastatic brain tumors and also have thromboembolic disease. So we ask ourselves, does the risk match the level of consent and the level of care? Has the patient had a craniotomy in the last 3 to 5 days? Do they have a brain tumor that has a high risk of intrinsic bleeding? Are there other contraindications to anticoagulation? And whether or not there's a yes or no, you can head to other local therapies or IVC filters, or if not, you should proceed with a baseline head CT or other baseline imaging. If there is not any active or recent bleeding, then you can proceed forward with systemic anticoagulation in the majority of patients. You want to have the patient at the highest level of monitoring possible with a very, very good nursing and physician protocol. And you should start heparin or other anticoagulation without a bolus or with a mini bolus and watch them very carefully. You may want to consider repeating head CT scans and watch their platelets, their red blood cells, and their coagulation factors extraordinarily closely. Prevention of thromboembolism is truly the best way we can help our patients. So for patients with high risk, we want to think about mechanical sequential compression devices, early ambulation. We want to think about chemical prophylaxis such as low molecular weight heparin, unfractionated heparin, direct thrombin inhibitors, etc. Usually they tend to be safe in all patients. And we want to prevent it across the board by early ambulation across all of our patients when possible. I want to transition and talk about other things that are very important across our patient populations, and they are occult or known immunosuppression. So 2 agents that are very common are steroids and cytotoxic chemotherapies. And importantly, they often present in an occult way. They can present with a neurologic symptom or other symptoms that come concurrently with neurologic symptoms. And they have a huge impact in the management of all medical issues, including those of the CNS. And they can be lethal if not promptly identified and managed. So steroids in CNS tumors. There is no consensus in management across the board. For CNS diseases, Decadron gets in the brain the best. There is more glucocorticoid effect and much less mineralocorticoid effect. The half-life is 34 to 52 hours. So once a day or twice a day dosing is completely sufficient. The old frequency of 4 times a day is just man-made. It's very important to consider once a day or twice a day dosing, such as in the morning and at noon, to avoid the deleterious side effects that all steroids carry that are particularly deleterious at night, such as insomnia, agitation, nocturia, etc. There are a plethora of short and long-term side effects of steroids, as we all know. Cumulative doses have been correlated across data sets to lower Karnofsky performance status and overall survival. Relatedly, hyperglycemia, usually from steroids, has been strongly correlated to a lower overall survival, more infections, and importantly, post-operative function loss in patients with brain tumors, particularly in eloquent areas. Many strategies to date to minimize hyperglycemia and the steroid effect have included modified ketogenic diets, and unfortunately to date, non-steroid alternatives are just not adequate to replace Decadron. However, currently many are being looked at. Some in the ICU include mannitol, carbonic anhydrase inhibitors such as Diamox, loop diuretics such as Lasix, VEGF agents such as bevacizumab, and many trial agents. As we all know, steroids cause a plethora of short and long-term side effects. There are currently efforts underway in the Society of Neuro-Oncology and other international societies to try to better quantify these into ways in which we can use across clinical trials and across FDA-approved agents. It's important to tell our patients, family members, and colleagues to actively surveil and manage these comorbidities. Cytotoxic chemotherapies in CNS tumors. Very important pearls that are not what we receive in our basic training and every year annual updates that I want to share with you. There are different types of cytopenias. First is neutropenia. The most common are in non-primary CNS tumors, such as brain and spine metastases, when people have systemic malignancies, and they are almost always treatment-related. Alternatively, lymphopenia is much more common in primary CNS tumors, both at baseline and related to treatment. And it's very important to remember that at baseline, the 31-year-old marathon runner who was just diagnosed with a seizure and a brain tumor has baseline qualitative lymphopenia, even though they may have normal numbers. Dysfunction is independent of absolute numbers when it comes to these blood counts. Thirdly, cytopenias. The thrombocytopenia is second most common in primary CNS tumors and also common in metastatic disease, and is almost always treatment-related as well. And lastly, anemia. Least common in primary CNS tumors and most common in metastatic CNS disease and systemic disease, and usually a combination of treatment effects as well as comorbidities. A little bit more on lymphopenia, because it's one of the cytopenias that is least commonly talked about and is most commonly occult and can rear its head in a very lethal way in patients affected with CNS tumors. This is an example of a study provided by Hughes et al., published in the Radiation Oncology Journal in 2005. And it looked at primary brain tumors, malignant brain tumors, treated with steroids and radiation prior to the initiation of chemotherapy for this patient population. And it looked at risk of infection and low CD4 counts as a surrogate of the function of lymphocytes. And for patients just getting radiation and steroids, before radiation, 100% of patients had normal CD4 counts. And during radiation, a quarter fell to below 200. And that's the level consistent with HIV or AIDS population patients. In those that had lowering of less than or equal to 2,000 during radiation, there was a dramatically and statistically significant more hospitalizations, infections, and inferior survival. And this is a slide provided by Dr. Stuart Grossman et al., presented previously at various venues. And this is a research slide just to show by a picture patients with low CD4 counts, levels at which a CD4 count is at HIV and AIDS defining criteria CD4 count, where this patient population stopped a typical chemotherapy regimen such as temozolomide in addition to radiation and steroids, and how profound and prolonged patients had a low CD4 count in qualitative and quantitative lymphopenia. I want to thank Dr. Grossman for the use of this slide. So the definition of lymphopenia can be variable based on patient population. The most common is the benchmark of HIV or AIDS at 400 or 200 respectively. And patients can present very atypically compared to other types of cytopenias like neutropenia. Instead, they can have viruses, funguses, atypical organisms, parasites, much less likely bacteria. It can be acquired, such as community-acquired pneumonia, PJP, formerly known as PCP, Candida, Legionella, Listeria, and there can be reactivation of organisms innately prior exposed in the patient, such as CMV, zoster, hepatitis, pertussis, diphtheria. So for the evaluation and treatment of these patients, a good example of what is a modifiable, evidence-based treatment we can employ is the treatment of PJP. It's based on probability and lethality, but we should have a low threshold for employing prophylaxis, treatment, and an infectious disease consult. Common prophylaxis agents include trimethoprim sulfamethoxazole, otherwise known as Bactrim. For patients with a sulfa allergy or thrombocytopenia, we should choose something else. That could be dapsone or pentamidine. Dapsone can be correlated with hemolytic anemia and metabolic acidosis. I want to transition now and go to a third category that is very important to disseminate knowledge across a wide population of subspecialists of a rapidly evolving area of medicine, and that's immune therapy. And this cartoon is to describe our interaction with foreign antigens or foreign offenders, whether they be bacteria, viruses, cancers, medicines, etc., and our own innate immune system. So broken down into more of a military-esque or war-like analogy, very similar to how our immune system naturally works, I think of our blood counts as being our armed forces and our Army, Navy, Air Force, Marine, Coast Guard. Each of our immune cells is uniquely made to fight a different fight within the human body. So immune therapy relies on the principles of first you must identify the offending agent. Next, you must present to the effector cells, or the cells that can do something about it and mount a fight. 3, you have to develop a specialized response to the specific offender and be able to kill only that offender and not have friendly fire or kill anything else you don't want to kill. You have to be able to magnify, mass produce, and optimize that response. And you have to appropriately stop the response when the war is over. Side effects of immune therapy on broad strokes are all across the board, and they tend to cause inflammation and itises because we're creating an immune reaction where we don't want to create a fight. So that could be altering the endocrine axis, the thyroid, inflaming the linings of the lung, hepatitis, enterocolitis, uveitis, scleritis, pancreatitis, and in the CNS, encephalitis, cranial nerve dysfunction, cerebral irritation, and leptomeningeal disease. The pictures you see are just an example of some rashes and a wicked case of pneumonitis that at first was thought to be an infection or tumor progressing, but was really just a reaction of the immune system fighting a tumor. I want to transition now to talk about biologics. That is a broad term to describe agents that modify certain biologic behaviors to create a disease-specific treatment. A few examples include rituximab, a monoclonal antibody to CD20. This is used in CNS and systemic B-cell lymphomas, many neurologic diseases that are autoimmune, such as multiple sclerosis, and many rheumatologic diseases. One of the most important takeaways is that this can cause reactivation of prior exposures or prior infections of hepatitis B and sometimes hepatitis C. And this can be a combination of rituximab, immune suppression, steroids, and the disease itself. An acute hepatitis panel is not sufficient for testing. Instead, we have to look at anti-hepatitis B core antibody as well as anti-hepatitis B core surface antigen plus or minus hepatitis B DNA titers themselves. And please refer to the graph on the right, and below in small print are several references that you can also get on PubMed and up to date. Other reactivations that can occur in biologics include tuberculosis, lymphomas, including post-transplant lymphoproliferative disease, and rarely PML. Lastly, bisphosphonates. Bisphosphonates are an increasingly utilized biologic that strengthen bones, particularly that lower the risk of bone metastases or strengthen the bone after bone metastases. It's also good for lowering the effects of osteopenia in patients with inherent osteopenia or other diseases that cause osteopenia. In cancer patients and in non-cancer patients, it can minimize pain because of micro and macroscopic fractures. And importantly, they have been shown to reduce skeletal-related events such as major fractures and loss of functionality such as ambulation, and thus improve overall survival and Karnofsky performance status. However, words of caution. Toxicities to the neurosurgeon and other specialists include acute fevers and myalgias. It's like having a flu syndrome because it induces like a cytokine reaction. It can cause GI symptoms, nephrotoxicity, and importantly, it can have an idiosyncratic osteonecrosis of the jaw and other sites. And then very lastly, a few other agents just to let you know about. We always have to remember about drug-drug and drug-herb interactions. Most importantly, we have to think about the liver and the CYP metabolism. Some drugs are inducers of the CYP metabolism. In other words, decrease the serum level of other drugs. For instance, dexamethasone, many chemotherapies, and many antidepressants. There are other drugs that are inhibitors of CYP metabolism and then can increase the serum level of other drugs, such as azole and antifungals, including oral and topical remedies. So you could put in a diflucan powder in someone's diaper, and that is absorbed and can create this effect. Also, many other chemotherapies and antidepressants can cause as well. So it's very important that we use our pharmacology or other colleagues to assist us in drug-drug interactions. And another thing to note is that hyponatremia, another very common and feared complication in our sick patients, can also be caused by drug-drug interactions as well. Common agents include diuretics, antidepressants, antipsychotics, anticonvulsants, COX-2 inhibitors, and many chemotherapy agents. And so I would like to end this lecture and welcome anyone to leave questions on live chat in the future. I want to say what a pleasure it was to do this lecture. I would be happy to hear from you, and I'm located in Atlanta, Georgia, and wish you all the best in your patient care, and take care, everyone.
Thank you very much, Dr. Dunbar. Do you mind if we ask you a few questions?
Sure, go for it.
Yeah, I'm just curious because I've been listening to neurosurgeons for a couple of days now, and it's nice to get a different part of the picture because obviously the treatment of brain tumors is not strictly surgical. Do neurosurgeons typically consult, and one thing I was surprised is the problems with bleeding disorders with tumors. Do they typically consult an oncologist when they diagnose a brain tumor?
That's an excellent question. I think multidisciplinary management of patients is becoming the norm, where both the complexity of medicine, the complexity of patients, and the international demand for multidisciplinary care. So the typical patient that's seen by a neurosurgeon has other internists involved, whether they're first emergency department doctors or in ICU, critical care medicine doctors, but increasingly hematologists, oncologists, or neuro-oncologists like myself are increasingly being consulted early and often for the examples of the complexity of care that you described. So my bias is to err on the side of consulting us because, as I like to say, life is a team sport, and when we work together, we assuredly have improved patient outcomes.
Okay, thank you, Doctor. And Slava has a question. Do you want to ask Dr. Dunbar the question, please?
Yeah, thank you very much for such a detailed presentation. I'm fascinating by this, by the sole fact that you're an oncologist. I was commenting earlier today that it's the only medical specialty that I would have thoughts about going into, because I found it, I think it must be very emotionally draining. But as an oncologist, I would like to ask you about the current treatments that are possible in the case of glioblastoma. I was asking these questions to other neurosurgeons, and can you please comment from your perspective? Thank you.
You're very welcome, and thank you. I'll tell you, it's a good time to be an oncologist because I describe it as evidence-based hope. There are real treatments really improving quality of life and length of life. So we couldn't be able to achieve that without our neurosurgical colleagues, so I thank you as well. To answer your question, my next lecture will go over the modern management of glioblastomas, but increasingly it is also multidisciplinary. The backbone of doing a maximal safe resection, followed by very detailed molecular genetic analysis of tumor, is paramount. And then increasingly we use a combination of radiations, different mechanisms of medicines, whether we think of them as traditional cytotoxic agents, immune therapies, or anti-angiogenic agents. And then now we even have FDA approved in the United States devices that are being used to modify the behavior of tumor, both new and at times of recurrence. And I think the story is being written that at a time of recurrence or progression, there are more and more effective therapies that allow patients to live longer and better. And I'll go into more detail in my next lecture.
Thank you. If there is still time, just another comment. I was been into the University Hospital Center in Zagreb last week, and I was on an oncology ward, and I saw a patient who had cerebral metastasis, and it was such a bad condition this patient was in. So, are those patients usually in such bad states? Please, I think they are, but can you comment on this?
Yeah, so patients with cerebral brain metastases are very heterogeneous in the way they present. Some patients with HER2 positive breast cancer or small cell lung cancer metastatic disease to the brain is one of the most common ways that patients present with their original cancer diagnosis. And other times, disease going to the brain or the spine is one of the last events in the natural history of a patient. And patients with asymptomatic brain metastases or oligometastatic disease, in which we think of as 1 to 3 metastatic foci with good performance status, could truly live many, many years. On the other hand, patients coming into a hospital setting with hemorrhage or vasogenic edema or very poor Karnofsky performance status often have less that we can do to treat them, more along the lines of steroids or radiation, and they have an inferior survival counted in weeks or a few months. So I think the principle to take away is that you have to look at the total patient and think, what is their diagnosis? Where is it distributed? what has their previous treatment been, what are their other active medical issues, and get together as a team of specialists and come up with what is the best way to help relieve suffering and to give them the best support. Sometimes it's aggressive treatment against the tumor, and sometimes it's solely supportive care.
One last question, Doctor. Thank you very much. Given the fact that all areas of medicine are exploding in development, genomics, nanomedicine, immunotherapy, how would you advise a young oncologist to train? I mean, what would you suggest incorporating into their training, given the fact that so many things are changing, and given putting your pulse on the future, what's going to happen in oncology? What would you suggest an oncologist to look at when training?
Sure, that's an excellent question. I would go to an internal medicine residency program, which in America is the basis of all of the subspecialties such as cardiology, gastroenterology, and oncology. I would go to a program that has a very, very strong clinical program, not necessarily solely focused on research, because there is nothing more precious than a strong clinical foundation that you will take with you for the rest of your professional career. Then it's to find good mentors that can help you find all of the different components of a successful oncology career, such as whether or not you think you want to be clinically based or research based, but really helping you make those decisions forthcoming. I think that the area of oncology is exploding as you described, and then going to the correct oncology fellowship program that meets your goals. Some people know a priori they want to be an MD, PhD and really want to work at the bench, and other people know they want to work with patients and want to be out there running clinical trials. And so it's about matching your professional goals with the right training program and the right mentors.
Very good. Thank you, Doctor, and thank you for an excellent presentation for part one. So we'll conclude this part one, and we'll see you in part two. Thank you.
Thank you.